Welcome back to the Deep Dive. Today isn't just another deep dive into medical literature.
No, not at all.
Today we are simulating a high-stakes environment. I want you to imagine the scene. The air conditioning is humming, your palms are a little sweaty, and you are sitting across from a stern-looking professor with gray hair and thick glasses.
Oh, that's a terrifying image to start with.
But an effective one. You're in the middle of your MD anesthesiology final exams.
We are putting you, the listener, in the hot seat today.
Exactly. And the examiner leans forward, looks over those glasses, and says, "Doctor, tell me about renal replacement therapy." Now, most people might just stammer out dialysis and, hope for the best.
And that would not go over well.
Not with us.
Yeah.
We have gone through stacks of material, Miller's anesthesia, ICU protocols, anesthesia review, to build the perfect 20-mark answer.
And that distinction between a casual answer and a true exam answer is... It's just crucial here. We aren't just chatting about kidneys today.
No.
We are synthesizing the physiology, the physics of the machines, the critical care applications, and most importantly for our listeners, the anesthetic implications. Because if you can't manage these patients safely in the OT, the definition, well, it doesn't really matter.
Right. So our mission today is to turn you into a senior resident who can handle this topic with complete confidence. We have a lot of ground to cover.
A huge amount.
We're going to break this down into a structured roadmap, just like you would for a long answer question. We'll start with the basics and definitions.
Okay.
Move into the physics, which I promise we will make understandable. Then the modalities like IHD, CRRT, and SLED.
And we absolutely cannot forget the vascular access and the anticoagulation.
Of course. And finally, the so what? The anesthetic management and the specific exam traps that catch so many people out.
The ones you must avoid.
So let's dive in. Part A, Introduction to Basics. Examiner asks, define renal replacement therapy. Do I just say artificial kidney?
You would probably get a polite nod and a very low score.
Okay, so what's the better answer?
You want to be precise. Drawing from the literature, like ICU protocols, the definition you want to give is, RRT describes all approaches to mechanical artificial support of non-endocrine kidney functions.
Non-endocrine. That's a key distinction right there.
It is. It's a huge distinction. The machine, it can't replicate erythropoietin production or vitamin D activation. It can't make hormones.
That's a filter, not a factory.
The perfect way to put it. It effectively replaces the filtration and the homeostatic functions. It is not just cleaning the blood. It involves the regulation of volume status, electrolyte balance, acid-base equilibrium, and the removal of all those uremic solutes.
So if I'm answering this in the exam, I'm emphasizing that it's a complete support system for homeostasis, not just a simple toxin filter.
That's the 20-mark answer.
Now, usually we talk about this in the context of AKI, acute kidney injury, or CKD. I noticed the literature, especially Miller, has shifted away from calling it renal failure.
Yes, the terminology matters. It reflects a deeper understanding. We speak of acute kidney injury, or AKI, now.
And we stage it.
Exactly. The medical community uses criteria like rifle or akin to stage this injury. The concept is that RRT is often a bridge.
A bridge to what?
Well, in AKI, you are bridging the patient through an insult like sepsis or surgical shock, giving the kidneys time to hopefully recover. In end-stage CKD, the goal is different. It's about maintaining life by replacing that function permanently.
So a temporary bridge versus a permanent replacement.
What?
Got it. Okay, so we have our definition. Now let's look at the exam paper itself. This pops up as a long question, a 20-marker. What is the structure the examiner is looking for?
Okay, a 20-mark question usually looks something like this. Classify renal replacement therapy, discuss the physical principles involved, describe the perioperative management of a patient on maintenance dialysis undergoing non-renal surgery.
That covers everything we're talking about today.
It does. It's a huge question. But you also get short notes, you see, often asking for CRRT versus IHD or anticoagulation in RRT.
And the VIVA.
The VIVA, the oral exam. They love to ask the practical, tricky stuff. How does the machine actually remove potassium? Or, and this is a big one, can you put a central line in the subclavian vein of a dialysis patient?
We will definitely get to that subclavian question later. I have a feeling that's a major trap.
It is.
Let's move to the second part of our intro. Indications. The sources all mention the AIEOU mnemonic. This seems like pure exam gold.
It is the absolute standard for recalling indications. It's an anesthesia review. It's in all the standard texts. But the nuance is in the details. You can't just list the letters.
Okay, let's walk through it then. A is for acidosis.
Right. But not just any acidosis, correct.
It has to be severe.
Severe and, more importantly, refractory. We are talking about severe metabolic acidosis, typically a pH less than 7.1 that is refractory to medical management.
Meaning you've already tried bicarb.
You've tried fluids, you've tried bicarbonate, and it's not working. Only then is RRT the answer.
Okay. E is for electrolytes.
And this one is critical, specifically refractory hyperkalemia.
High potassium.
A potassium level greater than 6.5 milliQL is a critical trigger. But again, the keyword for the exam is refractory.
You tried medical management first.
Always. If you tell the examiner you would start dialysis immediately on a patient with a K of 6.0 without trying medical management first, like insulin and glucose, or calcium gluconate for membrane stabilization, you might fail the station.
So you stabilize the membrane, you shift the potassium into the cells, and only if that fails, you remove it.
Exactly. RRT is for when those measures fail, or when the K is just dangerously high.
Got it. I is for intoxication.
This refers to dialysable toxins, things like methanol, ethylene glycol.
Antifreeze.
Yes, and lithium salicylates. The molecules need to be small enough and not highly protein-bound to actually be removed by the filter.
O is for overload.
Fluid overload.
Right.
I want you to picture the patient with anosarca, full body swelling with pulmonary edema, gasping for air, and they're just not responding to massive doses of diuretics.
You can't get the water off any other way.
You're essentially mechanically wringing the water out of them with the machine.
And finally, U for uremia.
This is the clinical picture. It is not just about a high BUN number. We look for uremic complications.
Such as?
Uremic pericarditis, which is an absolute indication. Uremic encephalopathy, so confusion or seizures. Or uremic neuropathy, the clinical signs.
Speaking of numbers, though, are there any hard biochemical triggers? Like if the creatinine hits 10, do we just start dialysis no matter what?
It's a great question, and the answer is generally no. ICU protocols mention some thresholds, like a BUN greater than 80 to 100 or a creatinine of roughly 7 to 10, but these are so context-dependent.
You treat the patient, not the number.
That's the mantra. You treat the patient. However, severe dysnatremia, so a sodium less than 115 or greater than a 160, that is a very strong indication for RRT to correct the balance safely and slowly.
And what about timing? Do we wait until it's a complete disaster, or do we start early?
The great early versus late debate. It's a hot topic. ICU protocols suggest initiating before complications become life-threatening, to optimize the patient.
So that seems logical.
It does. However, Miller is quick to note that major studies on prophylactic dialysis, especially in sepsis, haven't consistently shown a survival benefit.
So the jury's still out.
For some conditions, yes. But for us, for the anesthetist, the relevance is optimization. We want the patient's milieu interior, their internal environment, to be as normal as possible before we induce anesthesia.
You don't want to be managing severe acidosis and a potassium of 7 while the surgeon is cutting.
That's a nightmare scenario. You optimize the chassis before you drive the car in a race.
That makes perfect sense. Okay, let's move to Part B, Principles of Solute and Fluid Removal. This is the physics section. I'll be honest, I always struggled to visualize the difference between diffusion and convection.
It's a common sticking point. Let's use an analogy. Imagine you are making tea.
Okay, I'm listening. I can do tea.
Diffusion is like a tea bag steeping in a cup of hot water. You have a high concentration of tea particles inside the bag and a very low concentration in the water.
So the tea moves out of the bag.
The particles move across the membrane, the tea bag capered down their concentration gradient until it all balances out.
Okay, so that's diffusion. Movement from high concentration to low concentration across a semi-permeable membrane.
Exactly. And in dialysis, this is the main principle for removing small molecules, things like urea, potassium, creatinine. They are small, they're nimble, and they diffuse very easily. This is the primary mechanism in intermittent hemodialysis, or IHD.
So T-bag equals diffusion equals IHD. Okay. What is convection then?
Convection is like a French press coffee maker.
Oh, I like this.
You press the plunger down, right? The water is forced through the mesh filter by physical pressure, and it drags the flavor and the coffee oils with it.
It's not just waiting around.
It's not waiting for a gradient to do the work. It's being actively pushed.
So pressure pushes the solvent, which is the water, and the solvent then drags the solutes with it.
Precisely. We call that solvent drag. And because of this, convection is much, much better at removing middle and large molecules, things that are too big and bulky to diffuse efficiently.
Like what?
Well, in the ICU, we talk about removing inflammatory cytokines like IL-6 during sepsis. Convection is the heavy lifter for that. This is the principle behind hemofiltration.
So diffusion for small molecules like a tea bag, convection for middle and large molecules like a French press. What about ultrafiltration? It sounds similar.
It's related but distinct. Ultrafiltration is simply the movement of fluid, the plasma water itself, across the membrane. It's driven by a transmembrane pressure gradient. It's how we remove volume.
So if a patient is 5 liters positive in fluid balance,
We use ultrafiltration to literally squeeze that water out of their blood.
and osmosis, where does that fit in?
Osmosis is the movement of water from a region of low solute concentration to high solute concentration. This is less relevant for the blood circuit machines we've been discussing, but it is the entire principle behind peritoneal dialysis.
Right, the one that uses the belly lining.
Exactly. In PD, we put a hypertonic glucose solution into the belly, which then sucks water out of the blood vessels in the peritoneum by osmosis.
That is a crystal clear distinction, thank you. Now that we have the physics down to fusion, convection, ultrafiltration, osmosis, let's talk about the machines themselves. Part C, intermittent dialysis techniques. Let's start with the classic, intermittent hemodialysis, IHD.
This is what most people think of when they hear the word dialysis. It's the standard therapy for most chronic renal failure patients. The key characteristic is efficiency, pure, raw speed.
And how does it achieve that speed?
It uses very high blood flow rates. We're talking 300 to 400 milliminute on high dialysate flow rates running in the opposite direction.
It's fast, right? Like a few hours and you're done.
Very fast. A typical session lasts just 3 to 4 hours. And because it primarily uses diffusion with those steep gradients, it rapidly corrects severe hyperkalemia. If a patient comes into the ER with a potassium of 7.5 and ECG changes, IHD is the fastest way to fix it.
But speed comes at a price.
Always. And this brings us to the big exam trap regarding the disadvantages of IHD. The rapid removal of fluid and solutes causes two major problems.
Okay, what's the first one?
First, hemodynamic instability. If you pull 3 liters of fluid off a patient in 3 hours, their blood pressure often crashes. It just plummets.
And that's bad for all sorts of reasons.
Of course. And Miller points out a cruel irony here. This hypotension can actually cause a secondary ischemic injury to the already damaged kidneys, potentially delaying recovery in AKI.
So you're trying to save the kidneys, but the cure might actually be hurting them by dropping the perfusion pressure.
Exactly right. The second problem is dialysis disequilibrium syndrome, or DDS.
That sounds ominous.
It is. It's very serious. If you clear urea from the blood too quickly, the brain is still full of urea. Water then flows into the brain cells to balance the osmolarity, that's osmosis again, causing cerebral edema.
Swelling the brain.
Yes. The patient gets a terrible headache, nausea, and can even have a seizure or slip into a coma.
So for a patient who already has a brain injury or high intracranial pressure, IHD would be a really bad idea.
It is generally considered contraindicated. You would absolutely want a slower, gentler modality.
Okay, so let's talk anesthetic considerations for IHD.
The big one is timing, the #1 rule. You usually do not want to operate on the same day as dialysis.
Why not?
The patient will be dehydrated from the fluid removal, potentially hypotensive, and crucially, they will be systemically heparinized from the session.
Which is a bleeding risk for surgery.
A huge bleeding risk. The standard safe practice is to dialyze the patient the day before surgery. That's T-minus 24 hours. This optimizes their electrolytes and volume status, but allows the heparin to wear off completely.
T-minus 24 hours. Got it. Now, briefly on peritoneal dialysis, or PD. This is the one that uses the patient's own lining of the abdomen.
Right. It's often used in pediatrics or for highly motivated patients who want more independence from a dialysis center. From an anesthesia perspective, anesthesia review highlights a few key things. First, aspiration risk and respiratory mechanics. If the abdomen is full of 2 liters of dialysate fluid, it splints the diaphragm upwards. This reduces your functional residual capacity, your FRC.
So it's harder for them to breathe, and there's less oxygen reserve. So you drain the belly before induction.
Absolutely. Drain the fluid before you put them to sleep. It's a critical safety step.
What else?
Second, the catheter, the Tankoff catheter. It's their lifeline. Don't let the surgeon damage it, and be very careful with your laparoscopic ports. Also, remember the dialysate fluid contains a high concentration of glucose, so you have to watch for hyperglycemia, especially in your diabetic patients.
Okay, that makes sense. Moving on to the heavyweight champion of the ICU. Part D, continuous renal replacement therapy, or CRRT. Why is this the preferred method for critical care?
Stability. That is the one-word answer: stability.
How does it provide that?
In the ICU, your patients are often in septic shock, they're on multiple vasopressors, they are incredibly hemodynamically fragile, they simply cannot tolerate the violent fluid shifts of IHD. CRRT runs 24 hours a day, it removes fluid and solutes slowly and continuously, mimicking the natural kidney far more closely.
So no sudden crash in blood pressure.
Much less likely. It allows for incredibly precise volume control. If the patient is receiving 100 milliliters of antibiotics and nutrition an hour, we can set the machine to remove exactly 100 milliliters an hour. It's also much better for patients with high intracranial pressure because it avoids those rapid osmolar shifts we discussed with DDS.
Now this is where the alphabet soup gets a bit thick.
Yes.
CVVH, CVVHD, CVHTF. Can we decode these for the listener?
Yes, let's break it down, and it helps if you draw the circuit in your mind. All of these are continuous veno-venous therapies. Blood comes from a vein and goes back to a vein.
Okay.
First, CVVH. That stands for continuous veno-venous hemofiltration. The H is for hemofiltration. It relies entirely on convection.
The French press method.
The French press. You are pushing large volumes of fluid through the filter to drag solutes out, which means you have to replace that fluid with a clean, sterile replacement fluid.
Okay, so CVVH equals convection equals replacement fluid.
Perfect. Then there is CVVHD, continuous veno-venous hemodialysis. The D stands for dialysis. This relies on diffusion.
The teabag mess.
The teabag.
Yeah.
You have dialysate fluid running countercurrent to the blood on the other side of the membrane, creating that gradient. You don't necessarily need replacement fluid here, just the dialysate to accept the toxins.
So CVVHD equals diffusion equals dialysate.
Exactly. And finally, CVVHDF, continuous veno-venous hemodifiltration. It's the combo meal.
The best of both worlds.
It uses both diffusion with a dialysate and convection with a replacement fluid to get maximum efficiency for removing both small and middle-sized molecules.
There's one more, isn't there? SCUF.
Yes, SCUF, slow continuous ultrafiltration. This is the simplest one. No dialysate, no replacement fluid. It is purely for removing water, ultrafiltration only.
And when would you use that?
We use it in severe heart failure patients who are incredibly fluid overloaded but have otherwise decent solute clearance. It just dries them out slowly and gently.
So CRRT sounds great. It's stable, it's precise. Why don't we just use it for everyone who needs RRT?
Well, the downsides are significant: cost and complexity. It requires intensive, often one-to-one nursing. The machines and the sterile fluids are extremely expensive, and the patient is essentially tethered to the bed.
And there's more.
Oh, yes. Because it runs 24/7, you need continuous anticoagulation, which brings its own bleeding risks. And practically, the blood cools down significantly as it circulates in the extracorporeal circuit, so hypothermia is a very real and constant issue.
That leads us nicely to Part E, SLED, sustained low-efficiency dialysis. Is this the best of both worlds, then?
It's often called the Goldilocks solution. It's a hybrid. SLED uses a standard IHD machine, which is cheap and widely available, but you run it at much slower rates. A blood flow around 200 millimemor for a longer time, say 6 to 12 hours, instead of just 3 or 4.
So it's more stable than IHD.
Much more stable.
But cheaper and less labor-intensive than CRRT.
Exactly. It provides far better hemodynamic stability than standard IHD because the fluid removal is spread out over a longer period. It's very popular in ICUs that may not have the resources for full CRRT or as a step down for patients who are getting better.
Let's switch gears to the plumbing. Part F, access and anticoagulation. This is core knowledge. If I'm an anesthetist putting in a line for dialysis, where do I go?
For temporary access, we use these wide-bore double-lumen catheters, often called Quinton catheters, and the right internal jugular vein is king. It's the preferred site.
Why the right IJ?
Because it's a straight shot down to the right atrium, it offers the best, most consistent blood flow rates, which is what these machines need.
What about the femoral vein?
The femoral is usually the second choice. It's easy to access, especially in an emergency, and it's compressible if they bleed. But it does limit the patient's mobility, and it has a higher infection risk because of, well, its location in the groin.
And the subclavian. You warned us about this earlier.
Okay, this is critical. Never put a dialysis catheter in the subclavian vein if the patient has CKD or might need permanent dialysis in the future.
It's that absolute.
It's that absolute. I want you to remember this. Subclavian catheters have a very high rate of causing central venous stenosis, a permanent narrowing or blockage of the vein.
And why is that so catastrophic?
Because if you scar down that subclavian vein, you have just ruined the entire arm for a future AV fistula. You have destroyed their future lifeline. In an exam, if you suggest a subclavian line for a CKD patient, for many examiners, that is an automatic fail point. No questions asked.
Wow, that is a crucial takeaway. Save the arm. Now, regarding anticoagulation, the blood is outside the body, touching plastic tubing. It wants to clot.
It wants to clot immediately. The entire coagulation cascade gets activated.
So what's the standard way to prevent that?
Standard practice is heparin. It's simple, it's cheap, it's reversible with protamine, but it carries the risk of systemic bleeding, which is a problem in post-op or trauma patients, and of course the risk of HIT heparin-induced thrombocytopenia.
And the more advanced alternative is citrate.
Regional citrate anticoagulation. This is conceptually brilliant and very high yield for exams. You infuse citrate into the blood before it enters the filter.
And what does the citrate do?
Citrate chelates, or grabs onto the ionized calcium in the blood. The clotting cascade requires calcium to function. No available calcium means no clotting in the circuit.
But you can't return calcium-free blood to the patient, can you? Their heart would stop.
An excellent point. That would be fatal. So after the filter, just before the blood goes back to the patient, you reinfuse calcium chloride or gluconate.
So the patient's systemic calcium level stays normal, but the circuit itself is anticoagulated.
Precisely. It's a closed regional system.
That sounds perfect. No bleeding risk for the patient then.
Correct. It's ideal for trauma patients, liver failure patients, or post-op patients who are bleeding. The big risk is if the patient's liver can't metabolize the citrate load. You can get citrate lock or toxicity, which leads to a metabolic alkalosis and a drop in their systemic ionized calcium. You have to monitor it very closely.
Okay, let's look at Part G special situations. We touched on AKI versus CKD, but let's talk about the ICU specifically. Septic shock. There's a theory that running high-volume hemofiltration can clean the blood of sepsis.
Yes, the cytokine removal theory. It's a fascinating concept. The idea is that convection, the solvent drag, can pull out those inflammatory mediators like IL-6 and TNF-alpha that drive the septic cascade.
Does it work?
Well, it makes biological sense. However, as Miller points out, the clinical evidence from large trials is mixed. We haven't definitively proven that it saves more lives compared to standard doses of RRT. But in an exam, you should absolutely mention it as a potential, though unproven, benefit of high-volume hemofiltration, or HVHF.
And what about an ARDS? Acute respiratory distress syndrome.
In ARDS, we generally want to run the patient dry. A conservative fluid strategy has been shown to improve lung function and reduce ventilator days. RRT gives us a powerful tool to manage that fluid balance aggressively, removing fluid to reduce lung water even if the kidneys themselves aren't working.
It lets you uncouple fluid management from renal function.
Exactly.
Now we arrive at the core of our specialty. Part H, anesthetic implications. This is where the rubber meets the road for us.
This is 20-mark territory right here. You need to be able to break this down by drugs, timing, fluids, and monitoring.
Let's start with drugs. Pharmacokinetics and renal failure. Muscle relaxants are always a huge topic. What's the go-to, the safe bet?
The gold standard answer, the one you should always say first, is cisatracurium or atracurium.
Because of Hoffman elimination.
Exactly. They undergo Hoffman elimination, which is an organ-independent process. They degrade spontaneously in the plasma based on temperature and pH. The kidneys, they just don't matter. They don't even enter the equation.
Okay. What about rocuronium? It's so common now.
Rocuronium is primarily cleared by the liver and biliary excretion, but it has significant renal clearance as well. In severe renal failure, the effect is prolonged. You can use it, but you need to be very careful with redosing and expect it to last longer.
And vecuronium.
Avoid vecuronium. This is another one of those exam fail points. It accumulates active metabolites that can cause profound, prolonged paralysis for days in renal failure patients.
So cisatracurium is safe, rocuronium is use with caution, vecuronium is avoid. What about opioids?
Fentanyl and remifentanil are safe. They don't have active metabolites that accumulate. Morphine is the dangerous one.
Why morphine?
It metabolizes into morphine 6-glucuronide, or M6G. M6G is a more potent respiratory depressant than morphine itself, and it is entirely cleared by the kidneys.
So it builds up.
It builds up to toxic levels. A patient can look fine in recovery and then go into respiratory arrest hours later in the ward. It's a classic trap.
And induction agents.
Propofol is safe. Its metabolism is hepatic and extrahepatic. Thiopentone is an interesting one for vivas. In renal failure, you have hypoproteinemia, low albumin.
And thiopentone is highly protein-bound.
Exactly. So if albumin is low, the free fraction, the active part of the drug, increases significantly. You need to reduce the dose or you'll effectively overdose them.
That's a great physiological nuance to mention. What about our volatile agents?
Sevoflurane has a theoretical risk because of compound A accumulation and its fluoride ions. But in modern practice, with adequate fresh gas flows, it's considered safe. Desflurane is excellent for rapid recovery, which is always good.
Let's talk about fluids intraoperatively. This seems like a minefield.
The rule you must live by is fluid in equals fluid stays. These patients are often anuric. They cannot pee out any excess fluid you give them.
If you overload them,
You cause pulmonary edema, period. You must be incredibly judicious, use mini fluid challenges, 250 milliliters at a time, and watch the response.
and which fluid do we choose?
You should avoid lactated ringers if the potassium is high or unknown, as it contains potassium. But be careful with large volumes of normal saline, as that can cause a hyperchloremic metabolic acidosis, worsening their existing acidosis.
What's this answer?
Balanced salt solutions like plasmolite are often preferred if the potassium level allows for it.
Monitoring, this is huge.
Oh, huge. And the number one rule is about the fistula. Never, ever, under any circumstances, put a blood pressure cuff or an arterial line in the arm with the AV fistula.
Why not?
You can damage the fistula, you can cause a thrombosis, you can ruin their only access. Use the other arm. If they have fistulas in both arms, which is rare but possible, you use the leg.
Okay, let's talk complications.
Yeah.
Part H, Section 16. What goes wrong on these machines or with these patients?
Hypotension is the most common complication, both on dialysis and in the OR. You induce anesthesia, they lose their sympathetic tone, and because they are often volume depleted from their last dialysis session, the pressure just crashes.
So you need to be ready.
You need to be ready with your vasopressors before you even start.
We mentioned dialysis disequilibrium syndrome earlier. What about electrolytes?
Hypokalemia is a real risk post-dialysis, which can cause dangerous cardiac arrhythmias. And hypophosphatemia is often overlooked. It causes profound muscle weakness and can make weaning from the ventilator extremely difficult.
And hypothermia. We mentioned that with CRRT.
The CRRT machine is a giant heat sink. The blood goes out of the body at 37 degrees, circulates through all this tubing at room temperature, and comes back cold. You need aggressive warming fluid warmers on the return line, underbody warmers, forced air warmers, everything.
Okay, we are in the home stretch, Part 1, exam integration. Let's do a rapid-fire comparison for the mental whiteboard in our heads. Efficiency.
IHD is the most efficient, then
Yeah.
SLED, then CRT is the least efficient per hour.
Stability.
The complete opposite. CRT is the most stable, then SLED, then IHD is the least stable.
Cost.
CRT is by far the most expensive. IHD is the cheapest.
Perfect. Now, the Viva traps. We mentioned the subclavian line. What is the classic succinylcholine trap?
The examiner leans in and asks, the patient has a full stomach, needs a rapid sequence induction. Their last potassium was 6.0. Can I use succinylcholine?
And the answer.
The answer is a resounding, unequivocal NO. Succinylcholine raises serum potassium by about 0.5 to 1.0 MU/QL due to depolarization and potassium efflux from the muscle cells.
So if they started 6.0, they could hit 7.0.
And go into a sine wave rhythm and cardiac arrest right in front of you.
What if they dialyzed yesterday and their K is a perfect 4.5?
Then it is arguably safe, but many anesthetists would still avoid it just to be safe, preferring a high dose of rocuronium with Sigma-Dux if it's available. But specifically in the exam, if the K is high or unknown, SUX is a fail.
Another trap. The patient is hypotensive on induction. Should I give a 1-liter fluid bolus?
That's the trap. In an anuric patient, that 1 liter of fluid has nowhere to go. It goes straight to the lungs.
Causing flash pulmonary edema.
Exactly. The correct answer is to use small titrated boluses, perhaps 250 milliliters, or to go straight to vasopressors. The answer is titrated management, not open the tap.
Finally, how to structure that 20-mark written answer on paper.
Start with your definition, emphasizing the non-endocrine support. Then list your indications using the AIEOU mnemonic. Classify the modalities, make a small table comparing IHD, CRRT, and SLED. Discuss the physics briefly, diffusion versus convection.
And then the main body of the answer.
Then spend at least 50% of your time and space on the anesthetic management. Break it down. Pre-op assessment, checking that post-dialysis potassium and their dry weight. Intra-op, talking about safe drugs and fistula protection. And post-op, covering pain management and fluid restriction.
And a diagram.
A diagram is a huge bonus. Draw the CRRT circuit. Access, pump, heparin line, filter, effluent out, replacement in, and return to patient. It shows the examiner you understand the mechanics, not just the theory.
This has been an incredibly comprehensive review. Any final thoughts for the candidate walking into that exam hall?
Remember, RRT is life-saving. but it alters physiology in a fundamental way. Know your safe drugs. Cisatracurium, fentanyl, propofol. Respect the fistula. It is the patient's absolute lifeline. Treat the potassium before you touch the patient. And understand why you are choosing a modality stability versus efficiency. If you can explain the why, you will pass.
And for our listeners, I'd suggest grabbing a piece of paper right now. Seriously. Pause this and sketch out that CRRT circuit blood in, filter, replacement fluid, dialysate effluent, blood out. Lock it in your memory.
Absolutely. That muscle memory will help you in the exam. Good luck.
See you in the OT.